A 65-year-old man comes to the physician for joint pain and headache. He tells the physician that he is concerned he may have cancer because he's noticed that his headaches have been accompanied by a change in the shape of his head, and that he can't wear his favorite hats anymore as a result. Laboratory tests show serum calcium phosphate levels in the normal range, but an elevated alkaline phosphatase. The patient is started on appropriate therapy. Which of the following best describes the lesion this patient is most at risk for? Choice A, multinucleated cells in a hyaline cartilage matrix. Choice B, onion skin appearance on X-ray. Choice C, sheets of large cells with clock face chromatin and prominent endoplasmic reticulum. Choice D, combination of lytic and sclerotic regions with paraosteal elevation. Choice E, bubble-like lytic lesions in the epiphysis. I'll wait 5 seconds and answer the question. This should be a very easy diagnosis of Paget disease of bone. This whole thing where he can't wear his hats like he used to is very buzzy for what happens when there is constant bone remodeling. And you add on top of that, there is a normal calcium and phosphate level with an elevated alkaline phosphatase, which represents the fact that there is a lot of bone remodeling going on. So a big association you need to know with Paget disease of bone is increased risk of osteosarcoma. So choice D, combination of lytic and sclerotic regions with paraosteal elevations, is the correct answer. With osteosarcoma, I mean, sometimes you'll hear resources talk about how, like, the Codman's triangle and the sunburst sign. It's not that they would never give those to you, but you need to be able to recognize other high-yield things that they associate with osteosarcoma, which of course includes Paget disease of bone, and just this description about paraosteal elevation. Not much else to say there, so let's take a look at some of these other answer choices. Choice A, multinucleated cells in a hyaline cartilage matrix. This is referring to chondrosarcoma, which is the second most common malignant primary bone tumor. It's often found in the pelvis, and usually you need to be able to do a spot diagnosis on USMLE because they'll just give you a slide of the histology. It's pretty easy to identify because, as this answer choice says, it's in a hyaline cartilage matrix, so it just looks like cartilage, right? It has like the transparent cartilage-looking matrix, and you'll see the chondrocytes mixed in the matrix. Not much else to say there. Choice B, onion skin appearance on X-ray. This is referring to Ewing sarcoma. This is found mostly in children and adolescents, so you already know that doesn't really fit this patient because he's older. We all like remembering that whole translocation 1122 associated with it, and the whole onion skin pattern on radiography. That can be kind of hard to see, as well as the histology, small, round, poorly differentiated blue cells, especially because in a lot of images for the onion skin appearance will end up looking very similar to the sunburst sign that you see for osteosarcoma. So you're going to need to use some clinical clues to help you diagnose Ewing sarcoma. They have pretty similar age ranges, so Ewing sarcoma tends to happen in the shaft, the diaphysis, a little bit more than osteosarcoma, which tends to be more in the metaphysis. Ewing sarcoma tends to present with systemic findings more than osteosarcoma, so which is to say that Ewing sarcoma often presents with things like fever and fatigue. Osteosarcoma will often only have the symptoms near the bone, near the lesion itself, so the pain that's near the osteosarcoma lesion. Like I said, it's pretty hard to differentiate them. So unless they're just trying to give you a really hard question, they'll usually give you something like the 1122 translocation to let you know it's Ewing sarcoma instead of osteosarcoma. Choice C, sheets of large cells with clock face chromatin and prominent endoplasmic reticulum. This is referring to plasma cells, so mainly multiple myeloma. Obviously, it can be related to some other lesions like plasmacytoma. And since multiple myeloma is often diagnosed or suspected via serum immunoglobulin levels, they might also try to make you confuse it with MGUS or Waldenstrom. MGUS is easier to differentiate because MGUS is usually asymptomatic, so you just have a bunch of extra plasma cells, but it's not high enough to actually cause problems. Waldenstrom doesn't have a lot of the symptoms that multiple myeloma does, such as hypercalcemia and anemia, bone lytic lesions, and the spike in immunoglobulins in Waldenstrom tends to be IgM, whereas multiple myeloma tends to be IgG. But anyway, as I mentioned, multiple myeloma can cause lytic bone lesions, anemia, because the plasma cells are kind of crowding out the other cell lines. The circulating immunoglobulin can deposit and cause amyloidosis all over the body. And of course, the lytic bone lesions can cause hypercalcemia. They really like testing multiple myeloma in all kinds of different ways. Sometimes it'll be as simple as they'll just give you an elderly patient with a bone lesion, and you're supposed to infer that it's multiple myeloma. They might give you a couple extra details. But yeah, you have to have a very broad understanding of multiple myeloma and all the different systemic problems it can cause. Diagnosis of multiple myeloma often involves, as I mentioned, testing serum immunoglobulins, and you'll find an M spike. It's called an M spike, but don't mistake that to mean IgM. M spike just means there's a bunch of monoclonal immunoglobulin in the blood. Like I said earlier, multiple myeloma is often IgG instead of IgM. And another thing you can find is rouleau formation in RBCs. So you'll have a blood smear and the red blood cells will just be kind of stacked on top of each other or stuck together. It's called a rouleau formation. We can probably chit-chat about multiple myeloma for like 10 minutes alone, all the different ways they like testing about it, but we gotta move on here. Choice E, bubble-like lytic lesions in the epiphysis. This is just me kind of using a roundabout way of describing a giant cell tumor, also known as osteoclastoma. This is a benign bone lesion, but it's still aggressive. It can cause lytic bone lesions in the metaphysis and epiphysis of long bones. And as mentioned, you'll look at the x-ray and it'll look like a bunch of bubbles caused by the lytic bone lesions of the osteoclasts kind of growing out of control. And that's mostly what you need to know for that one. So bring it back, osteosarcoma. You need to know that, yeah, it's mostly found in younger patients, especially in patients with retinoblastoma. But you need to also know that in elderly patients, you can see osteosarcoma if they have Paget disease of bone. And you need to know the presentation of Paget disease of bone itself, right? You have normal PTH, normal calcium, normal phosphate. You'll just have elevated ALP because the bone is constantly remodeling itself. I hope you found this video helpful. I'll see you in the next one.